Thank you for joining me today to talk about educating for professionalism. And this is a topic that I've thought about for a while, and with the support of the department, I was able to further explore this in teaching scholars. So at the end of our discussion today, you'll be able to define professionalism, judge the need to educate for professionalism, including methods of teaching and evaluating, and determine if the implementation plan that we're using in hematopathology, if that's right for your lab or division. Okay, so now I'm going to ask for some interaction. So professionalism, how do you define professionalism? I'm just looking for words that you associate with professionalism. If you are off-site, you can text me at 916-599-8044, but just shout out some words. And if you're shy, you can text me too, if you're here. On time. Courteous. What was that? Courteous. Sorry, what was that? Altruism. Ethical. Integrity. What was that? Socially aware. Socially aware. Oh, and I just got a text. Integrity. A second on integrity. Socially aware and respect. Expertise. Honest. Anything else that anyone thinks of? This is a pretty good list. Just kind of spitballing, thinking about these things. And although expertise and certainly knowledge-based skills and knowledge are part of professionalism, it seems that we focused a lot on more what's termed as non-cognitive in the literature or behavioral skills. And I only put this slide in to show that everybody has their own definition of professionalism. And so how you define it is up to you. And how we are going to think about professionalism today, although we certainly do agree that excellence in scholarship is part of professionalism, we are going to focus on these ideas of professionalism that you all pointed out as well, these behavioral aspects of professionalism. And this is the combined taxonomy from the Association of American Medical Colleges and the National Board of Medical Examiners. And we're going to focus on the altruism, honor and integrity, caring and compassion, respect, responsibility, accountability, and leadership. So we're going to discuss the need. So we've defined it. Maybe, why do we even worry about it? So with society, is there a need based on society? And if you're reading any popular press articles, you'll see that society does think that there is a need for educating for professionalism. And we're going to focus on this one right here, bad med students, bad docs, in USA Today. And that article was based on a study from Papadakis' group at UCSF, where they found that medical students who were assessed as irresponsible in medical school were 8 times more likely to be disciplined as doctors by the state medical boards. Both irresponsibility and diminished capacity for self-improvement showed a significant increase. And those traits were stronger predictors for future disciplinary actions than test scores or grades. What about employment and need? There was a study looking at resident contract renewal at Thomas Jefferson, and they found that residents with a lower professional attitude had a lower rate of contract renewal than those with higher professional attitudes ratings. And this was in spite of clinical judgment, knowledge, and data gathering scores. Just what about your experience in need? Have you ever worked with someone who you thought was knowledgeable and academically competent, but they may have been viewed by you or by others as offensive? They couldn't communicate effectively. Maybe they brushed people the wrong way or inhibited teamwork, or just was irresponsible. So answering the question, is there a need for education in the behavioral aspects of professionalism? Headlines suggest we should. The data suggests we should. And our experiences suggest we should. But behavioral skills as part of residency and fellowship training, in my experience, we really tend to focus on the knowledge, the procedural skills, clinical judgment when we're teaching and we're developing a curriculum. So why isn't it a particular focus? It's really hard. It's really hard to talk to people about behaviors and where they need improvement in behaviors. It's also very time consuming. And in the scheme of things, it's not really all that common. That study looking at the house officer contract renewal, over 600 residents were evaluated, and there was really only 3% that were having problems with professionalism. Some possible other reasons why we don't do this as effectively or as consistently as we should. Maybe we don't think it's our job, or that we're not good at it, or we don't know what to do, or that adult learners cannot be taught character. And the reason that I think you might think this is because I have thought these things at various points in my career. So let's start with, is this part of your job? So understanding human behavior and maintaining relationships. So that probably was not discussed with you as part of your job when you were being hired, or even discussed after you were hired as an integral part of your job, unless you were in human resources. But to be successful in any career, these skills are really indispensable. And although knowledge and clinical judgment is certainly crucial for our line of work, some businesses are moving from IQ, or intelligence quotient, to EQ, the emotional intelligence quotient, to XQ, or your personality quotient. If you're a residency or fellowship director or on the core competency committee, you really know this is part of your job because it's part of the ACGME core competency, and you rate the residents and fellows on these milestones. So for our Hematopathology fellows, in the professionalism, there's receives and provides feedback. That's the one at the top. And what we're looking for is that they're able to modify and maintain changes in practice based on feedback, and that they actively seek and provide feedback. They also, the professionalism number 2 is demonstrating accountability, honesty, and integrity, that they're anticipating team needs and taking a leadership role. They institute corrective measures, and that they're personally responsible. Additionally, we want them to be reliable. Professionalism 3 is cultural competency, so that they're either exemplary or that they model cultural competency, being able to recognize cultural differences and biases. And in the core competencies, they separate out interpersonal skills and communication from professionalism. And the ICS-1 communicates with healthcare providers, families, and patients. We want them to be able to effectively communicate with all parties, and with ICS-2, personnel management and conflict resolution. We want them to be able to independently manage conflicts and complaints, and anticipate as well as mitigate potential conflicts and complaints. So those are the milestones that we are evaluating our fellows on. So these other aspects, I'm not good at it, I don't know what to do, adult learners cannot be taught character, we'll get to in a moment as we further discuss educating. And so what tools do we use for education and professionalism on these behavioral aspects? So we can turn to the more standard educational models of self-study and reading, lectures and didactics. We can use more interactive models with small group discussions or simulated interactions. But in busy day-to-day practice caring for patients, what's most practical is modeling and feedback. I would like to read this quote from Lewis Cass: "People may doubt what you say, but they will believe what you do." And sometimes we forget how powerful modeling can be and what the impact our verbal and nonverbal cues can have. And at the same time, it allows us to reflect on our own behavioral skills. So if you feel like you need some help with figuring out what to do, there are various courses that you can take through UW Medicine, Organization of Development and Training, these POD courses, as well as more specific faculty development seminars through the UW Medicine. And this is some reading that I would recommend. If you're wanting to focus more on difficult conversations, The Crucial Conversations is really an excellent book, and Crucial Accountability. If you're interested in being able to recognize behaviors in yourself and others and being able to manage those behaviors so that you can have a more productive and successful interaction, any of the books on emotional intelligence. And mindset, for understanding how our mindset can influence us as teachers and learners. And if you are in the camp that adult learners cannot be taught behavioral skills, mindset would be the book I would start with. But if all of this is a bit too intense, I can recommend some books from Cesar Millan and from Buck Brannaman and how they approach working with dogs and horses. Their approach helps us understand how these nonverbal cues and our emotions can really influence others' behavior. One of Cesar Millan's tactics is through modeling. And so Cesar models behavior for the owner, and his pit bull daddy, he models behavior for the dog. And one of the terms that I really like from Cesar's teaching is the calm, assertive leader. And to think of that when you're going into any kind of a difficult situation. So not all situations are amenable to this, but it helps when modeling behavior if you can have a clear rationale for your thoughts and your actions. And this behavior was modeled to me by Larry Burgart, one of my attendings at the Mayo Clinic. And if you haven't been on HemePath for a while, what happens if you're on the marrow service or morphology is that you get slides in a palette, and all of those slides on the patient will also be given to you with paperwork. So that should all be correct because the accessioners have put it together, compiled it, and gave it to you. But Larry taught me to double check that and make sure that it's correct because we're all human and we can all make errors. So if I just say, let's look at all of this paperwork and check the slides and the paperwork and make sure the same patient is on here, the resident or fellow may think, well, is this attending just obsessive compulsive or what are they doing? And so if I tell them that I'm double checking the slides and paperwork because I'm protecting the patient, making sure mistakes happen, I want to make the right diagnosis on the right patient, and that ultimately, it doesn't matter if somebody made a mistake before it got to us, we are ultimately responsible. And if you have an experience or a story you can bring into that, that can really hit home. So I can talk about this unfortunate situation with Linda McDougall where the right diagnosis was made on the wrong patient and she ended up with a bilateral mastectomy and no cancer. So moving on to feedback. Here's Coach Wooden of UCLA and Bobby Knight of Indiana demonstrating two different models of feedback. So first of all, for feedback to help, we have to provide it. We want to reinforce the areas where they excel, and we want to be constructive for areas where they need improvement. And for a nice effective model to think of is Sachdeva's model of being specific, objective, consistent, and timely. So some of you might say that you haven't given some types of feedback because you've had bad experiences. Once you give that feedback, with the other, the recipient not being very happy with it. And studies have shown that that's true, that adult learners are often dissatisfied with the feedback they receive. And I want to talk a bit more about this study from Southern Illinois University, where they looked at performance after and perception of feedback. And they were looking at medical students being evaluated on tying surgical knots, and they separated them out into a compliment group and to a directed feedback group, and to see if they would improve. Performance improved with the directed feedback as opposed to general praise. However, student satisfaction was significantly higher in the praise group. Yeah, so the study's conclusions was that student satisfaction is not an accurate measure of the quality of feedback. However, learning is a function of the quality of feedback. So then where does this lead us? This really points out that we can try to help set the stage to get our learners into the right mindset to ensure that that feedback is received well. And I like this tactic from Dr. Gracio from the University of Colorado, that what she'll tell her students and residents is that studies have shown that adult learners are often dissatisfied with the feedback they get. I can give you feedback that will make you feel good or feedback that will make you a better doctor, and my job is to make you a better doctor. And that gets everybody on the same page. So to further help both the learner and the teacher, it's really helpful to think about the mindset of both parties. And so with the fixed mindset, there really is no room for improvement because your ability or character is an innate talent and cannot be significantly changed. Whereas the growth mindset, that is something that you can enhance and you can build upon through hard work and effort. So I'm using an example here of a behavioral skill of communication, but you can substitute knowledge-based skills, athletic abilities, anything in here for fixed and growth. And so an example using communication, somebody might say, well, she's a good communicator, or she's a good manager because she is just a natural communicator. Whereas in the growth mindset, she's a good manager because she has worked very hard to develop these communication skills. So in the growth mindset, you're not labeling the person. So in a fixed mindset, you would say, he is a rude person. In a growth mindset, you'd say, he was rude in that situation. So when you're thinking that way, it's a behavioral attribute that can be improved upon. So you're working towards excellent, and it doesn't necessarily mean that you'll be excellent in what you're doing right now. So not only do we have to have the right mindset, but we want our feedback to be constructive. We want to address the problem and not the person. Be clear, direct, thoughtful, and respectful. And feedback is also not only sharing your opinion, but also offering a solution for change. So I want to give a couple examples of behaviors and looking at non-helpful and helpful ways to give feedback. So reflecting on a specific behavior rather than attributing to somebody's personality. Unproductive feedback would be, you were rude and unprofessional in that situation. Whereas helping that person see what happened and helping them move forward, it sounded like you weren't telling Jean, or sounded like you were telling Jean that she isn't careful and isn't being truthful. She will likely be more responsive and improve if you talk about how the specific problem occurred and how you will work together to resolve it. You can see with that, you're just going to get everybody in a discussion and not put somebody on the defense. You want to describe your perception rather than passing judgment. As opposed to thinking or saying you have no insight into your deficiency in communication, I feel you did not recognize that you upset Sean when you discussed the faulty immunostains with him. Next time, when you plan to discuss a sensitive issue, think about what the best approach might be to get the results you are hoping for, and let's discuss what your plan is prior to the discussion. So integrity. So this is a common quote that you might find that's related to professionalism. Integrity is doing the right thing when no one is watching. And certainly that's great, and we want everybody to do the right thing when no one is watching, but people can be trained to behave predictably. And it relies on habit, not necessarily behavior modification, for insight, for applications for other situations. So if we think of integrity in the growth mindset, it's a modifiable trait that we can improve through work and effort. And I like this quote from Colonel Eric Kale, that integrity is not the absence of failure, but the ability to move forward from it. And thinking of wherever we end on our road to success, there's often roadblocks and failures along the way. And that's life, and we just have to keep moving forward and improve and not get bogged down when we didn't do as good of a job as we would have liked to at that time. So evaluation, how are we going to evaluate for professionalism? Different forms of evaluation can include direct observation through self, peer, and faculty assessments. In our line of work, we don't have much opportunity for patient opinion surveys. We could look at critical incident reports, simulated tests like OSCEs, or paper-based tests like the Defining Issues test or the Minnesota Multiphasic Personality test. But in a busy practice, a good and practical option is direct observation and assessment. But you can ask, can we confidently assess professionalism by direct observation? And certainly by the review of Volosky and the opinion article by Cohen, no single measurement or set of measurements is yet proven sufficiently reliable and valid to meet the demanding psychometric criteria of professionalism. But yet that doesn't mean that you can't gain useful information from multiple observations over time. And the Papadakis study suggests that we can. We can have observed assessments and show what's going to happen in the future and try to intervene. The medical students who were assessed as irresponsible were more likely disciplined by the medical boards. This was 3 medical schools evaluated with similar findings across the United States. So University of Michigan in Ann Arbor, Jefferson Medical College in Philadelphia, and UCSF in San Francisco. was a 13-year time frame looking at 235 physicians disciplined by 40 state medical boards and having 469 control physicians. So this study would suggest that that educators can credibly evaluate professionalism by observation. One model for evaluation by observation that was developed by Sharon Phelan's group at the University of New Mexico, they were looking at observed behavior by faculty in order to assess and intervene. What they wanted to do is identify problems in behavioral areas and develop a system that would allow trending of potential problem behaviors. They wanted to allow for candid documentation of single events so people wouldn't have to be worried like if, this could be a one-off, maybe I shouldn't say anything. They could say something. It's just a candid documentation of a single event without isolated occurrences being blown out of proportion. They had a checklist of 7 behaviors and then a 5-point Likert scale to evaluate, and no action was taken by the committee unless 2 or more negative evaluations had been submitted. And importantly, the emphasis was that the evaluations were to help. They weren't to penalize. And I think that also shifts faculty's mindset. If they're thinking that, oh, I'm going to say this and it's going to, penalize them, when it's really something we're trying to help them with, that also helps, that enters into the discussion. We're trying to help, not penalize. The 7 traits from the Phelan study included reliability and responsibility, maturity, critique, communication skills, honesty and integrity, respect for patients, and signs of a chemical dependency or mood disorder. And they looked at 525 students. Of that, 6% had more than one concern, but only 10 students actually required intervention, so they had 2 or more concerns. And based on the committee decision, the intervention could be quite minimal, just having a discussion with the chair of the committee or with the dean, or it could have been more significant with extensive counseling or a leave of absence. So what are we doing in hematopathology? So this is a work in progress, and we are using education and evaluation and have a plan of action through evaluating the behavioral aspects of professionalism. For education, as I discussed, in a busy world of practicing medicine, modeling and feedback are really good ways to educate people. We also are using some didactics and group discussions, but more modeling and feedback. The evaluation is primarily the observed behaviors. So potential problems are discussed at the monthly education committee meeting to identify potential problems for timely intervention. So this is a committee decision to ensure that the concern and action is appropriate and sufficient for intervention. So any issues that are of a concern, they can be emailed or called to the fellowship directors if it's something that needs to be discussed more urgently, or it can be put into the 360 evaluation. And this is an example of what we're working on for the 360 evaluation that's based on the Phelan study. This print, of course, is too small for you to see, and so I'm going to break each one down in a bit more in depth. And what I really liked from the Phelan study that we're including here is that not only is there this main topic of reliability and responsibility, but in the Phelan study, as what we're doing in our evaluations, there's descriptors to help people think about, well, what are we meaning by reliability and responsibility? And so everybody is on the same page. So for reliability and responsibility, the descriptors that we're adding in can be depended upon, follows through on tasks, arrives on time. For critique, that they can accept criticism, that they look at themselves objectively, and that they take steps to correct their shortcomings. For maturity, that they behave respectfully, they accept blame for failures, that they do not make inappropriate demands, and they are not abusive or critical during times of stress. For honesty and integrity, adhering to professional and ethical standards, that they're honest and that they correct errors. For signs of a mood disorder or chemical dependency, I think that that's kind of a tough one, and so I think having some descriptors in there as well can help people think about, like, well, how do I know if there's something going on? So a change in personality or dressing habits or neatness, excessive irritability or anger beyond control, if they're withdrawn or distracted. And work-life balance, that they can appropriately manage stress and appropriately manage fatigue. And lastly, communication, that they're listening well, that they effectively identify emotional concerns in others, and that they do not engage in blocking behaviors. So blocking behaviors being hostile, derogatory, sarcastic, loud, or disruptive, or verbal or nonverbal cues of non-participation. And the nonverbal cue of non-participation that comes to my mind is eye rolling. So when you're seeing that, that is something to take note of and hopefully further discuss. So when we're asking for assessments based on direct observations, we want to avoid interpersonal issues. We're focusing on the problem, not the person. And whenever we're rendering judgment or talking about somebody's behaviors and rendering an opinion, we want to reflect on our own behaviors and see where we can make improvements. So as far as the course of action, what our plan will be if something is deemed necessary to intervene, remembering that it's going to be a conscientious and deliberate decision-making process, that it's not going to be made by one person, it's going to be made by our education committee, and that discussion of the intervention will be made with the trainee as far as what approach should be taken. And perhaps that might just be a discussion, maybe it will be some coursework or classes, maybe it will be counseling or therapy, and this last, perhaps we need to involve the GMS, and don't get worried about involving the GMS and involving them early. If there's something that you're not totally sure what to do with, get them involved. Just because you get them involved doesn't mean that there's going to be a negative mark or a negative letter put into that trainee's file. The other thing is to recognize when we're out of our realm of knowledge, if we need to have help because of chemical dependency or psychological or psychiatric issues. So now that we've talked about education, evaluation, and supportive interventions, does it create any tangible results? And this is the study from University of Colorado. This is the largest and most comprehensive study on remediation. And they looked at medical students, residents, fellows, and attendings. And most common deficits were medical knowledge, clinical reasoning, and professionalism. Most of the people in their remediation program had more than one deficit, and as they went up in training, fellows and attending physicians, they had most trouble with professionalism. There was 151 learners in their remediation program, and 90% were successful. And so that's a pretty good success rate, so I think that would suggest that intervention can help, although it was noted that it required substantial resources, a lot of time to help with these things. And what they defined as successful was that the students, residents, fellows, or attendings were in good academic standing, they graduated from their training program, or they were practicing medicine without any restrictions. So I would like to end up thinking about the attending as a coach and utilizing the growth mindset that all learning, including professionalism, is a process. And so as the coach, don't take it personally, don't make assumptions, use Sachdeva's feedback model of being specific, objective, consistent, timely, and I think timely is always a difficult thing for me, and to give feedback and accept feedback with respect and dignity. So for those of us who are getting feedback, it's hard for people to give you feedback, so keep that in mind as well. So I would like to use these two legendary coaches to exemplify the growth mindset and the fixed mindset from John Wooden from UCLA and Bobby Knight from the University of Indiana. I won't read the Knight quote, you can read that for yourself. But I really like these John Wooden quotes. So, did I make my best effort? If so, you may be outscored, but you will never lose. And you aren't a failure until you start to blame. So with that, I would like to thank the Department of Laboratory Medicine for supporting me in the Teaching Scholars Program, because I was really able to spend a lot more time and think about this and explore this topic. And I would like to thank the Hematopathology Laboratory faculty, staff, residents, and fellows for their support and encouragement through all of this, because they hear a lot about professionalism from me. So thank you.
Thanks, Lori. I was like, we're very lucky here in our program because we usually have really, really high quality residents and fellows. But I think eventually if you stick around here long enough, there's gonna be one of these people who just sucks up a huge amount of your time. And so this is good kind of stuff to bear in mind. So thanks, Lori. Jeff, you
I had a question a little bit about the Colorado study, and I was wondering just in maybe a little bit more detail whether, like, what does that actually mean that 90% showed some improvement? So some of the things we talked about, I couldn't give one word for the beginning because
Yeah.
I tend to, and I'm an associate program director and also on the clinical competency committee, and professionalism is something that sort of is tough for us to deal with because it's really not, a lot of these things are not continuous improvements. It's not like you're supposed to start off the residency a little bit racist and then get better. And, you know, whereas you are supposed to know nothing about flow cytometry at the beginning, know some, more, and then aspirationally know a lot. Honesty is one problem that challenges me. Like, so if you're just a little bit dishonest, you're not honest.
Mm-hmm.
Okay, and so it's really more dichotomous. And so my explanation, my definition of professionalism is always the absence of non-professionalism, which it's all those things. And if you just stop doing one of them, you got a problem. So were of those 90%, were there racists, pathologic liars, abusive people that got better? Because what Dan was getting at is we're not usually dealing with someone with a bell curve of professionalism and trying to push people back up off the slope of it to the middle. We're dealing with 3 standard deviations off. Does that have hope? Is there evidence that you showed Trump for a reason, I think.
Yeah.
So is there hope?
And that's, everybody can have their own opinion.
Is there hope?
So, so I need to repeat the question.
Okay, please.
And I'm trying to figure out how to do that. But is there hope? And I think that there is. Is there, because there's the dichotomy of you don't just come in, you're not a little racist and then you get better. I mean, there's this dichotomy between being not professional and professional. And I think that there is hope, and I think that mindset book, actually, made a light bulb go on for me. And as far as those kinds of things, more cultural biases, they weren't in any of the studies that were looking at interventions. They didn't really talk about that. It was more so as far as maturity, responsibility, following up on orders, communication skills. Those were the bigger components of professionalism, and each study looked at things a little bit differently. But I think if we think about it as that people may fail at one point, or they may have failed in this situation, but that doesn't necessarily mean that they're a failure and that they will continue to fail. And if we have that in mind and try to work through it and point it out to them and discuss it in a constructive way, that can be helpful and that can help them improve. But with that too, you have to be ready to recognize, is there something bigger at play that I am not capable of handling? Like, is there a drug problem here? Is there a mood disorder? And so I think that's also an area of challenge for us, like at what point do we are we able to recognize that and get that additional assistance? But a couple years ago, I would have said no. There is no hope. But I am very hopeful now. And I think by setting the frame and making people feel safe and setting everybody's mindset in that, we all fail, we all need to learn, and these aren't attributes that are set for you. These are skills, and we can work through them and improve on them. But somebody has to be in the right mindset to be able to improve. So we can try to help get them there. Yeah.
Lori, there was a very nice talk, so thank you for educating us all about this. And just reflecting on the topic and thinking that professionalism is usually very much defined in terms of individual terms. It's a characteristic of a person. But what about the culture, the environment in which a person works, because that interacts with their characteristics, and it's often the collective environment that can either promote or sometimes inhibit individual professionals. So what does the literature say about that aspect of this?
Yeah, so the question. So the question is regarding the environment and the literature on how the environment affects professionalism and how people learn professionalism. And actually, I didn't run across anything looking at that. There might be something specifically out there, but all of the studies I looked at was just looking at the behavior problem, not at what was surrounding them to influence that behavior. But certainly, as you suggest, the environment is going to influence that behavior, and which makes us all accountable for behaviors in ourselves and what we see in others, and trying to create a culture of professionalism and holding all of ourselves accountable to be professional and making everybody comfortable to give us feedback at any point. So not that the attending or the director is only giving feedback to the other attendings or the fellows, residents, medical students, that feedback goes both directions. So I think that's, I don't have any studies to tell you about, but it's certainly a crucial component.
In some sense, that's modeling it to a certain extent.
Modeling, yeah. Yes.
Yeah, just to follow up in your last comment. So I think an important component of a successful teaching program is to be able to receive and provide feedback. So and one of the challenges to do that is for the to create a safe environment for the residents to be able to provide the feedback. So can you comment on that? Did you do any exploration in our program to know if there is a safe environment to do that?
Yeah, so the question is about a safe environment, an exploration of the question about and incorporating a safe environment into feedback. And almost every, when you're talking about communication, emotional intelligence, any of these books or different sessions that you'll go to talking about any interactions that you're going to have, one of the first things that they will tell you is to create a safe environment and make a respectful environment. And so you don't want to go out to some area where everybody's around and then start giving them feedback about something that might be sensitive. And so taking them to a safe location is crucial, and there's a lot of, I didn't see any studies like taking people into a safe environment or not, but that is extensively discussed, and that's a really great point about the safety of the environment, and not only about the safety of the environment that you're in when you're talking about it, but just safety to express yourself, so that the residents and fellows can feel that they can give, they see this, I feel like I can give feedback to my attending because I feel safe. I don't feel like I'm going to have retribution, and that they will appreciate that. And that's where that's giving and receiving feedback with respect and dignity. And I think we always think about that, and it's always tough when you get feedback to be like, oh, great, thank you, I did something wrong. And so always keeping in mind to just give it a moment to settle and let it sink in and understand so that you don't go on the defensive. And when we create that culture of safety or a safe environment, I think that helps a lot.
So I kind of disagree with Dr. Baird's kind of assessment of it's a binary, that you're either professional or you're not professional, and I kind of see it as a spectrum of that different people fall under. And your talk was mainly focused towards trainees, but I think that professionalism training at all levels would be kind of an important thing, just because no matter where you are, you can always get better, in my opinion. And so is there any talk about like having this be something for continuing education that's required for medical professionals, or?
Yeah, and so the question is about having professionalism training for attendings, and that professionalism is something that you can work on throughout your lifetime. And certainly, I focused on the training on our fellows and our residents here, but certainly this is applicable to everybody, and that we should be applying it to ourselves and reflecting upon ourselves and our own behaviors, because we can't model effective professionalism if we aren't being professional. So there's those pod courses, and there's some faculty, UW Medicine faculty development sessions, but honestly, there's not a lot. You have to search them out, and those pod training, those are probably the best. And then periodically, there's various, like Sarah Kim gives great discussions on communication. She gave us a grand rounds not that long ago. Let me find that pod so you can see that. So those courses I've heard are very good, and those happen more frequently as opposed to specific faculty development courses. But honestly, I've had to do just more reading with various books, and then looking at the literature and seeing what's been done. And so what we've been doing in hematopathology is kind of looking at it as an overall process, and that the faculty and the trainees are all involved in this together. And so when we do have small group discussions or didactics, we're all there to hear them. So So, but that's a great point and a great idea, and I mean, perhaps that's something we could look at more seriously in our own department as far as creating more of a professionalism seminar series for faculty as well as the residents and fellows.
Curious, you mentioned the 365-degree evaluations. I'm curious how that can potentially impact this, comparisons to traditional evaluations, and what may be the knowledge component versus some of these other professionalisms that may be elucidated a little bit better by the 365.
So the question is about the 360 evaluation and how that would compare to the traditional evaluations. And so kind of two components to that. So the traditional evaluations, if they're based on the clinical competencies, a lot of what's being asked is quite similar, although there isn't anything about mood disorder or chemical dependency in the current clinical competencies. But most of the other things are covered, but just maybe in a different way and not explained as well, like communication skills. But the other aspect of the 360 evaluation is not right now, we had just, or not right now, but in the past, we were using just faculty evaluations. And so 360 evaluations, getting peers, getting the staff, getting the supervisors to also render opinions. And that, some of those people will be able to render an opinion of knowledge and skill, but most of that will be how they've interacted and what the professionalism is. And everybody is going to have their own experience. And what I experience as a faculty member could be different than what the resident experiences and different than what the accessioning tech experiences. And so having those different experiences to know where we can focus help is good. And I think that's the thing to also focus on, because we're trying to help people. We're not trying to make this punitive. We're not trying to put red marks in people's files. What we want to do is identify areas to help them. And sometimes different professionalism behaviors will be more obvious with staff or more problematic with staff and supervisors than it might be with an attending. Yes?
I feel obligated to say that, like a lot of universities are different. I think in this university, in our department, we consider honesty in research and so forth as a tremendous degree of professionalism. I think Dr. Fong talked last year at something, he talked about how many dishonest research articles there were out there and how many people cheat. I think that this department, and I think the university, holds very high in terms of maintaining professionalism. And I think that if people at the top maintain that high level, then everybody else knows what the right thing to do is. I have one thing to comment about environment is important or not. I had an experience many years ago where I saw a particular section of a laboratory, but not at the university, where there was very poor professionalism and people all around disliked the people in that section, and the supervisor changed, and 1 year later everybody said what a wonderful group that was. So that particular person changed the entire environment and changed all the people. So environment is very important.
Yeah, so the comment was on the environment and how in a different lab, how the supervisor was making a very uncollegial, unprofessional environment for the people who worked there. And when that supervisor left, that completely changed, and all of the people around them appreciated that that group had become much easier to work with and more professional. And I think that's something, when you mention that, it just goes right into this emotional intelligence aspect of things and how some people can get the best out of people and other people don't. And in funneling that ability, if some people have learned how to do that already. Some of us are in that process. And being able to develop and learn that ability to make people safe, make people enjoy what they're doing, not make people, but help them enjoy what they're doing and be more professional and part of a team. Any other questions or comments? All right, thank you.